screen and use the relevant passcode. Also, can I remind you that whilst our presenters will answer questions at the end of their presentation, you can actually type questions at any time for them. Can I suggest you don't leave your questions to the last minute, as we will aim to finish strictly at 8 p.m. Eastern Standard Time. Hopefully you've responded to the pre-webinar questions via the link in your confirmation email, and I'd be very grateful if all participants could take a moment at the end of the webinar to answer the exit survey questions, as this information greatly helps us in evaluating this webinar and others in the series. I would now like to introduce and sincerely thank Dr. Irwin and Mr. Errol Lim, who will be our presenters for tonight. Irwin Lim is a rheumatologist and director of BJC Health. Irwin also established the Sydney Spondyloarthritis Centre to improve the diagnosis and management of patients with ankylosing spondylitis and related inflammatory spinal disorders. Errol Lim is a physiotherapist, managing director of BJC Health and co-founder of the Sydney Spondyloarthritis Centre. Errol has been a physiotherapist since 1998 and started to have a specific interest in inflammatory disease when he commenced work with rheumatologists in 2004. Since working in this multidisciplinary setting, he has seen a great need to further educate physiotherapists and other health professionals regarding inflammatory disease, especially that of ankylosing spondylitis. Without further ado, I'll hand proceedings over to our first presenter for tonight, Irwin Lim. Thanks very much, Irwin.
Okay, thanks, Jen. Thank you everyone for participating. It's nice to see so many people actually willing to spend a Monday evening with us on this format. I purposely titled this talk, "If you don't know what to look for, how are you going to treat it?" Because one of our major problems with this disease is a massive delay in time to diagnosis. And I think I'm going to develop that story in much more detail. I'm going to start by showing you a disclosure slide. Both Errol and I work together, and we're directors of a group arthritis clinic. You can see our disclosures there. I probably won't be mentioning any of the drugs specifically made by any of these companies, but I will mention TNF inhibitor therapy briefly because that has been one of the major advances in this field, but I'll tell you more about that later. So I want to start by a statement that inflammatory back pain is common. And for all of you health professionals, I bet you see this. And some of you may recognize it more commonly than others. We all see back pain. We know it's ubiquitous. It's important for you to understand that up to 5% of chronic back pain is inflammatory. And that, of course, makes it a very large problem. Now, the prototype of inflammatory back pain is ankylosing spondylitis, which most of you should have heard about. But I want to make a point that it is not all inflammatory back pain that is ankylosing spondylitis. Okay, and again, I'll make that point a bit further on. When I talk about ankylosing spondylitis, a lot of people have seen this graphic. And it documents the same patient with ankylosing spondylitis over the years, and you can see him gradually getting worse. Now, I've already seen some of the names of the participants, so some of you are barred from answering this, but you'll see from 1972 to 1973 that this man is actually standing taller. And this is where I'm going to call for some audience participation. Can someone type the answer as to why this man is standing up straighter? And I'll give you a couple of seconds before telling you the answer. I'm looking down at this box where I hope someone will type something. Someone has written iphosphonate therapy, and another person has written self-limiting condition. And another person has said physiotherapy. Well, the reason he's better from 1972 to 1973, and this is one of the major features of ankylosing spondylitis, is that it doesn't just affect the spine. And in fact, it very commonly leads to advanced osteoarthritis in the hips. And this gentleman had bilateral total hip replacements, which is why he's standing up straighter. Okay? Now, while I put this up as an image for ankylosing spondylitis, I would want, by the end of this talk, that you understand that that's not the image I want in your brains. Because if this is the image of ankylosing spondylitis you look for in your clinics, we're going to miss a significant number of people. If you Google, you'll see pictures of this describing ankylosing spondylitis and the classic body habitus. Again, yeah, while it's important for you to understand this is the late stage, end stage disease, our focus is not actually allowing patients to look like this. And if you have this image, you're going to miss these people. But you may see patients like this. You can see the loss of lumbar lordosis. You can see this person starting to develop the body habitus. And I'm sure you've seen people like this. What I'm hoping is that you'll think about people like him. So this is Michael Slater, of course, and he has ankylosing spondylitis. And the purpose of me putting a picture like this is for you to understand that a person with ankylosing spondylitis, when they present, usually, hopefully it will be someone like you or me or Michael, where you can't really tell that they have classic features of Angspon. I put this slide in really for that last line, that worldwide the average delay in diagnosis is estimated to be 9 years, and that's quite long. And during that time, there's a lot of suffering for patients. These are Australian figures, and this comes from some research, I'll bet a questionnaire type research done by Lionel Schechner, who is a prominent rheumatologist interested in ankylosing spondylitis in Melbourne. And his group found that in in Victoria, the mean time to diagnosis was 10 years from the onset of symptoms. And that 2/3 of the patients with ankylosing spondylitis had definitely seen a physiotherapist. And you can see there that 16% had seen 3 or more physiotherapists before a diagnosis was made. I've also put in figures for chiropractic, and you can see half were seen by chiros and 9% had seen 3+. And there's actually many more in the list, like osteopathy, patients who, naturopaths, patients have also seen multiple GPs before the diagnosis is made. So the bottom line is the diagnosis is being missed. And that's not through any fault of any one individual. It's that it's a difficult diagnosis to be made. But if you're more aware of it, we hope that we will be able to make the diagnosis a bit earlier. Now I put this up because most recently there's been a campaign called the Don't Turn Your Back on It campaign, and these posters are being placed in GP surgeries around New South Wales to remind patients that just because they have chronic back pain, and it's often missed that it could be inflammatory back pain, and that's one of the purposes of this talk, is to try to get you guys to think about inflammatory back pain. So my next question, and I'm hoping some of you will take the opportunity to type answers, is what are features of inflammatory back pain? And again, I'm going to give a couple of seconds for you guys to type in some answers, because I want to make sure we're on the same page when we talk about inflammatory back pain. Please feel free to type something. So I see Margaret typing night pain, people talking about rest pain, avoidance of physical activity, inflammatory blood markers, I should say, and stiffness at the end of the day. And let me already correct some of those, because some of those are not necessarily correct. With inflammatory back pain, actually most patients like physical activity, at least early in the disease, because they feel much better. Inflammatory blood markers are something I'll address, because in some patients they're elevated, but in many they are not. And chronic dull soreness, that's pretty unspecific when I read that. Night pain is one of the specific features. So let me show you some of these. So how they present is with chronic spinal pain and stiffness. Generally, the story is that it starts insidiously, so it builds up gradually. It tends not to be a sudden onset. Quite a specific story is that patients point towards their buttock when they say lower back pain, because that's where the sacroiliac joints are. The pain is typically worse after rest. So if someone's in a long car ride, or they've been in the plane and then they have to get up, they are stiff. They feel much older than they are. Night pain is classic. They can fall asleep, but they wake up in the second half of the night with stiffness or pain, and often they'll find it quite hard to go back to sleep. So you'll get patients saying that they need to have a shower, or they need to pop a couple of Panadol or an anti-inflammatory to get back to sleep. Classically, at least early on, the pain actually improves with physical activity. So these are patients who like being active, and particularly for males, they typically are sporty because they found during their lives that that keeps them going. As opposed to some types of mechanical back pain, the pain does not improve with rest. It actually gets worse, as we've said. So those are features of inflammatory back pain. This is the inflammatory back pain symptom screener that you may have come across on the Don't Turn Your Back on It website, and that's a website you can find by just Googling Don't Turn Your Back on It, and I do encourage some of you to have a look at it, because this is a website that is very easy to understand for your patients, and you may be able to point patients who you are suspicious of having inflammatory back pain to this website. And you can see that patients typically are young because the pain starts before 40, it starts gradually, and it's the features we've talked about: improving with exercise, not improving with rest, and having night pain. So one of the reasons that the diagnosis is so delayed is because the classification and the way we diagnose it is quite confusing. I don't know how many of you have seen this, but this is a classic slide in rheumatology. And in the center you'll see is ankylosing spondylitis, but you'll see a whole range of other terms and classifications and diagnoses that rheumatologists use, from psoriatic arthritis to uveitis, which is an inflammatory eye problem, to reactive arthritis, which is an arthritis that occurs after sexually transmitted diseases, or severe gastroenteritis. And you'll also see ulcerative colitis and Crohn's disease, which are the two main inflammatory bowel disease, where patients present with gut problems and diarrhea and blood and mucus per rectum. The reason for this slide is that all of these diseases share a common pathogenesis, and they also seem to overlap a lot. So it's this concept of spondyloarthritis describing these groups of patients, and that if they have feature A and feature B, we might call them psoriatic arthritis, but if they have feature A and feature C, they might be labeled something else. But generally they're considered very similar diseases, and one or many of these diseases may run in the same family. So I just want to start making this clear, because from here you'll see how difficult the diagnosis can be, but also you may get clues as to how to make the diagnosis a bit more easily. So in the spondyloarthritis group, so SPA for short, you can have patients who have predominantly axial or spinal problems, and you have patients who have predominantly peripheral, meaning peripheral joints like hands or wrists or elbows or knees. And you can see that we've tried to break them across. But once again, I want you to understand that there's the word predominant because you can still have overlap, okay? Because these groups of patients are similar. Let me now show you the criteria for someone to be diagnosed with ankylosing spondylitis. And you'll see it comes from 1984, and that's 2 decades ago. And the bottom line is what's in red. You can be diagnosed with ankylosing spondylitis if you actually have X-rays, which is what they mean by radiological criterion, showing sacroiliitis, which means damage at the sacroiliac joints. Now this is a major problem because ankylosing spondylitis is a disease that is really defined by X-ray changes. And unfortunately, X-ray changes occur really late in the disease, and they're estimated to take 7 to 8 to 10 years to develop. So by default, if you make the diagnosis based on an X-ray, you are only going to be able to diagnose the patients very late in their time course. And that's one of the major problems with this diagnosis of ankylosing spondylitis. So a group of experts in this field tried to correct this. And if you think of any disease process, you obviously have a phase of symptoms early before the diagnosis is made. And so they came up with this term axial spondyloarthritis to try to better describe this entire disease course, with ankylosing spondylitis and the actual damage on x-rays occurring late in the disease. Okay? And if you are looking at the phase, which is to the left of that dotted line, prior to there actually being x-ray changes, you can still have a disease, just that you have negative x-rays. There are other ways to make the diagnosis, and I'll try to bring that to the fore in a moment. And again, this is a really busy slide, and I don't expect you to kind of remember any of this because you'll get handouts, but I want you to understand that, again, the disease diagnosis and classification is quite complicated, and rheumatologists use a whole range of features to help make the diagnosis, and that's the point for me showing you this slide. One of the clues in making the diagnosis of ankylosing spondylitis is the fact that a lot of patients have more than just spine complaints. And in 42% of patients, they have other associated features. And for those of you who've been following my kind of argument, you'll see that of those 42%, a high percentage have had inflammation of the eye, anterior uveitis, a percentage have inflammation of the skin, psoriasis, and a significant percentage have inflammatory bowel disease. That's what IBD stands for, or a combination of all these features. And those are the clues and the hints which make you start thinking of the back pain that these patients might have being related to inflammatory back pain and being related to a disease such as ankylosing spondylitis. I recently came across this image, and I thought it was quite good in trying to understand the pathway for inflammatory back pain. So I show this to you. So when all of us see patients, you try to, with back pain, you're trying to work out why, right? And of course, a large number become non-specific. But if you talk about it in broad brushstrokes, you have other pathologies, like serious pathologies such as tumors or I suppose neurological conditions. You can have mechanical back pain, and then there's this arm that we estimate at about 5% being inflammatory back pain, and we've of course just spoken about the features of inflammatory back pain. Now if you then follow that inflammatory back pain along the branches, a proportion of patients will stay having vague inflammatory back pain. Some will get better, but a proportion will then enter this classification group called axial spondyloarthritis, and those go with the slides that I've just shown you, where they fulfill those criteria. Now, not all of those groups will end up being AS, is the point of this. Some people will never actually get X-ray changes consistent with AS, but a proportion do, and they then follow down that branch. And that's the way I think it may help you understand these terms a little bit better. So the diagnosis can be difficult, and it's difficult for doctors and difficult for rheumatologists as well. And so we all need to have a very high index of suspicion to try to make this diagnosis. And the benefit, I suppose, I as a rheumatologist have is that we use quite a few investigations to try to help work out the diagnosis. So we all take a history, so we're all privy to the same symptoms. I suppose, again, as a rheumatologist, I look out very strongly for the associated features that I mentioned before to give us clues. We use imaging, and I'll show you some images soon. Someone previously mentioned raised inflammatory markers, and yes, they're helpful when they're elevated, but I'll make the point that at least 50% of patients with inflammatory back pain do not have abnormal blood tests. Okay. In fact, this is why this group used to be called seronegative spondyloarthritis. Sero meaning serum, and negative, obviously, blood tests are negative. A very useful hint as well, at least earlier in the disease, before there's a lot of long-standing damage, is that patients often respond very well to your non-steroidal anti-inflammatory drugs or to the COX-2 inhibitors. And they basically, in terms of stiffness and pain, feel much better on these medications. So a proportion of these patients tend to self-medicate anyway because they've worked out what works. I mentioned that there is a link within families, and that's because of a genetic marker called the HLA-B27, and a high proportion of these patients will have this gene. Again, the gene is useful when it's positive because it helps. It's one extra piece to the puzzle, but it can also be negative in the disease. So, it doesn't rule in or rule out a disease. The other problem in trying to interpret an HLA-B27 is up to 9 to 10% of the Australian population as a whole have the gene. So again, it's only useful in the
Please excuse the interruption. I'm just having technical issues. Won't be a moment.
for a sec there. So the point I was trying to make was that as practitioners, you all are privy to these patients, and you may not have thought of them, but I'm going to show you a few pictures that may help. So enthesitis, tendinitis is very common, and one of the ways these patients present is with recalcitrant tendinopathy or enthesopathy. You probably do not see them when they have acute eye disease, but it's an easy history to elicit because patients rarely forget a painful red hot eye. This you won't miss. These are psoriatic nails that you can see. So people get funny ridging of the nails. They get lifting off of the nail bed called onycholysis. The picture on the bottom of the toes, which look like sausages, that's called dactylitis. And if you ever see a sausage-looking finger or toe, think about psoriatic arthritis and this group of diseases called the spondyloarthritis, because that's where it occurs. And just to make the point that these are terribly painful and destructive problems, I've put on a bone scan of someone with dactylitis, and you can see the tracer, which is the black areas, being uptaken in a sausage finger, and it's a terribly destructive process that occurs. Again, these are examples of psoriatic nail disease, and they're hard to miss. So these are all clues. Okay, so you can only diagnose this condition if you're aware of it, and I've listed these conditions where I'm sure at least some of you have come across them. Recalcitrant spinal pain that sounds funny, that there's a lot of night pain, spinal pain in a young person. I think the story of fluctuating buttock pain, if you elicit it, is again quite specific. And then the other features, family history, psoriasis, bowel issues, uveitis. Patients often have in combination with their spinal pain, the involvement of peripheral joints, including big joints such as the wrists, the knees, the ankles. And the joint involvement can be just one joint or a number of joints. It can be asymmetrical. It can involve the chest wall as well. And the reason we bring all this to attention is that years before you see someone with this body habitus, they'll present with all those other features. Okay, so I keep trying to highlight those features because we don't want to wait till they actually develop this deformity before the diagnosis is made. A few slides about imaging. I've already said to you that one of the Achilles kind of heel of this diagnosis is that ankylosing spondylitis is made based on X-ray changes, but X-ray changes occur late. Importantly as well, the X-ray changes are really hard to report. And when they do studies getting a bunch of radiologists and rheumatologists in a room trying to report the same X-rays, you invariably get huge differences in opinion, often very surprisingly different. Now, this is an anterior-posterior view of a pelvis X-ray, and the sacroiliac joints are being graded. And let me see if I can get a cursor to show you. These are the sacroiliac joints, and if you keep looking at these areas, oops, sorry, I'll move back one. So you've got these areas here, which are the sacroiliac joints, and that's a normal, okay, because you can see the joint line in between, and the bones on either side of the joint line are not overly sclerotic, and there's no erosions. Now let me show you grade 2, and on the right side there's a little bit more sclerosis and a bit more irregularity, and grade 1 it's considered maybe a little bit irregular. But the point I'm going to make, even though these are classic images that are being chosen to show you, is that it's not easy. And the difference between grade 0, which I showed you there, grade 1 and grade 2 are often mistaken. And to get a diagnosis of angspon, you need to have bilateral grade 2 at least. Now grade 3 is a little bit easier, where you see a lot of blurring of the joint line, a lot more sclerosis of the bone. But again, in normal practice, when the positioning of the patient may not be perfect, when there might be feces in the intestine obscuring your joint margins, it can be very difficult to make the diagnosis, and the bottom line is it's often missed. Grade 4, which is the final one, should not be missed because it's complete fusion and loss of the sacroiliac joints. So grade 4 tends to be the easiest and the least missed for the obvious reason. In addition to the sacroiliac joints, you can get these excessive bone formation, and they're called syndesmophytes. And at their most advanced, these bone projections grow straight across and connect the vertebrae, and that's your classic bamboo spine. Again, we'd rather find the patients and treat them before this happens. Now, in patients who do not have X-ray changes, we now have the advantage of MRI to try to make an earlier diagnosis of spondyloarthritis. And while this one looks very obvious, where you have that patch of white being due to a lot of inflammation in the bone, again, I need to the caveat is that in normal practice, it's never this clear. In addition, if a patient's being sent for an MRI of a lumbar spine, most of the settings of the MRI are designed to look for mechanical problems such as a disc or nerve root impingement, and those settings will not actually pick up bone marrow edema. So MRI is not a tool to just say, give me the diagnosis. The MRI settings are crucial to get the correct diagnosis, and so you have to actually suspect the diagnosis, ask for the appropriate settings to get the answer. And this is just an MRI, again showing the white areas representing bone marrow edema in the vertebral bodies. Okay, so one of the reasons why I'm happy to do a talk like this to implore people to try to think about inflammatory back pain and then this diagnosis of spondyloarthritis and ankylosing spondylitis is that people's lives can be much better if we actually make the diagnosis earlier. And that's because we know more about treatment now. We know what works, and we have new medications to treat this disease. This is the classic recommendation slide for ankylosing spondylitis. Errol will talk to you about physical therapy and exercise in a moment, but you'll see on the top that you have NSAIDs, and with NSAIDs they also mean COX-2 inhibitors. And what I mean by these drugs are anti-inflammatory drugs. And let me mention some names: Voltaren, Indesid, Naprosyn, Nurofen, I suppose to some degree, Feldene, Celebrex, Mobic. So these are widespread use anyway, but they are the drugs which are extremely useful for this condition. And at the bottom you'll see TNF blockers, and this is a whole bunch of new medications which are terribly expensive but highly effective for these conditions, particularly in patients who fail to respond to anti-inflammatories, physical therapy. And if I start with the non-steroidal anti-inflammatory medications, rightfully, in the general community, there's a little bit of a distaste for the use of chronic anti-inflammatory use, and that's because they do put pressure on the heart, they can raise blood pressure, they can irritate kidneys. But in a disease like ankylosing spondylitis, where the clear-cut problem is excessive inflammation at the areas affected, these drugs definitely have more benefit than risk. And apart from helping pain, symptoms, and therefore function and how people get on with their lives and enjoy their lives, there's also now a body of evidence suggesting that they may actually slow down progression of the disease. And don't get bogged down with the numbers, but that's really what this slide was meant to trigger me to tell you. And so you may find your local rheumatologist using these agents more and more in a regular fashion in these groups of patients. Now, in patients who do not respond to anti-inflammatory diseases, life used to be very bad because they would follow that progression in that slide that I put the red cross across, where they actually get deformed by these diseases. But 10 years ago in Australia, we got access to this whole new range of injected medications called TNF inhibitor therapy. And some of the brands, just in case that's what you would have heard of, would be Humira, Enbrel, Symphony, or Remicade. And these agents have really revolutionized the treatment for people with severe ankylosing spondylitis. And the classic comments for people who've been suffering for decades with this crippling disease is that these are life-changing drugs. Now, I don't have enough time to tell you all about them, but there's pros and cons with these anyway. But for the classic person who gets onto these agents, who does not have any other options, they truly are a great change in the therapeutic armamentarium that we rheumatologists have. And I think that ends my section. And at this stage, I'm going to hand over to Errol to continue this talk, and then I'll be here at the end to help answer any questions. Thank you.
Hello, I think I'm on. Again, thanks, Irwin, and thank you to everyone for giving up your Monday evening to listen about ankylosing spondylitis. And again, it's with great pleasure to be able to speak to you about the management of AS, or spondyloarthritis. And I think Irwin's done a wonderful job in the half hour that he's had in talking very quickly about the management of AS. And the reason why we titled this section Physical Therapy as opposed to Physiotherapy is that, many of you in the audience tonight aren't physios, and I suspect that many of you are in the applied sciences realm and are really specialists in human movement. And so I think it's pertinent that we have a look at AS management from this perspective. Now, you've just seen that slide with Irwin has brought up, and really we're going to concentrate in this light yellow box, which is where therapists like us really should be concentrating. And really the stuff in the yellow that you see there can really only be done if we've identified that these patients already have inflammatory back pain. So I bring you back to the title of our talk, which is really, if we're not thinking of inflammatory back pain, we'll miss it, and hence we don't then have the opportunity to actually attempt to educate people about it and even prescribe the appropriate exercises for these people. Now, firstly, I'd like to thank a good friend of mine and physio over in Tassie, Janet Milner, for this slide. She has a special interest in AS, and also she's doing her master's research in AS. She came up with this slide to sort of encapsulate what factors we need to consider when managing SPA or ankylosing spondylitis, specifically to do with exercise prescription. And really, the titles and the factors that you see there, such as assessment and monitoring, and really all of them, are pertinent in terms of exercise prescription or management of any sort of injury or condition. But there are a few of them which have a particular AS-specific focus. And the topics that I'll be speaking to you about will be around assessment, safety and specific AS mobility, and medications, which Irwin has already touched upon, and how that affects exercise prescription. So if you go firstly to assessment, and when I say assessment, I'm more concentrating here, I guess, to some extent on objective measures of some sort. There is an immense amount of assessment that's specific to ankylosing spondylitis. And what I throw up now is a Wordle. For those of you who don't know, my daughter has to do Wordles at school, and this is a program that she's told me about. So I put together all the different assessment tools that are used specifically for AS. Many acronyms there with very, very long words, and I think it's best for you to probably best Google them or have a look at AS resources to have a look at what really they measure and what they do. But in essence, what they use for is for ongoing monitoring for people with these particular conditions. And again, it's something that can be used all the time. But we don't have the time, unfortunately, to go through each one individually. And so in order to keep it simple for today, I've chosen specific movements that often get restricted in ankylosing spondylitis that may be used. Again, if you don't use the particular measures above, you may use these ones in practice to, again, monitor patients to see whether they're improving or they're not improving. And at times too, if you've got suspicion that someone has inflammatory back pain, perhaps looking at these particular segments may give you a clue as to whether they're presenting with some sort of inflammatory pain or not. Again, just a reminder, these particular movements are not a diagnosis for these group of conditions, but they again help generally in the assessment and ongoing monitoring of them. Now, the next point when we are considering exercise prescription and management is safety, and that specifically around ankylosing spondylitis mobility. The first of which are looking at, and if I use my laser pointer here, looking at specific segment mobility. And so if we look at lateral flexion here, just imagine if someone has a particularly stiff segment, more often than not, the segment below or above moves a little bit more in order to compensate for this stiff segment. So in terms of ankylosing spondylitis management, in trying to give them more mobility exercises, we may in fact at times be creating a more mobile, hypermobile joint and perhaps creating some sort of instability in that position. So that's one consideration. Other considerations in the management of AS would be taking into account the stage of disease that a patient presents. These group patients typically have flares at times, and they tend to suffer a lot of fatigue. So do many of your chronic pain patients that you see. And so these are considerations, especially with exercise prescription. Now, as I've just mentioned hypermobility, another consideration is hypomobility when it comes to a side effect of osteoporosis. Patients with long-standing disease and perhaps patients who have taken prednisone for a long time can have osteoporosis as a side effect, and this is definitely something that needs to be taken into consideration, especially with manual therapy and that of exercise prescription. Now, I use this slide to talk about the effect of medications with exercise. In that I thought it was the opportunity to speak about the evidence that exists for exercise in AS. So there's some 200 papers investigating this actual subject topic. Unfortunately, of the systematic reviews that have been done, the evidence isn't that great, only at about silver level, and there isn't great evidence for dosage or frequency or the setting of exercise. And I guess I'll break for a minute, and I don't have a specific slide on hydrotherapy, but I thought in talking about exercise setting, we all know that hydrotherapy is extremely useful for this group of patients. Unfortunately, there isn't the evidence to back it up, as many of these papers have been poorly researched. But in terms of anecdotal and historical evidence for hydrotherapy, it is, and in many countries, a fundamental of management. And I think the best way to think of hydrotherapy would be to think of any modality that we utilize in terms of exercise prescription or management, and that really just throwing a modality on isn't going to be very, very helpful, but how we use that individual modality itself. And to summarize the evidence, really there is good evidence to show that exercise with TNF blockers have better outcomes than just the TNF blockers alone. And so with that, hence, a particular group called ACES has recommended that a combination of drug therapy and regular exercise is really the best way to go. Now, if you were expecting me to give you AS-specific exercise tonight, unfortunately, again, we don't have the time to go through specific exercises. But what I'd like to point out that AS, in terms of the treatment of it, is just like any other condition that you'd see. And in terms of exercise prescription, it's no different, except, of course, for the considerations which I've just outlined. But really, it comes down to your assessment and your judgment, especially if your judgment is made on sound, fundamental movement principles. Really, you can't go wrong. And so, if you wanted AS-specific exercises, then there's a bunch of resources that you can get online and free. And if I can point again with my laser pointer, this one on the left corner is a group of 10 video exercises that were formulated by Arthritis Australia with Michael Slater. There are free apps available, Ankylosing Spondylitis being one, which has free animations in terms of exercise training. There's also a free app from the Ankylosing Spondylitis Association in the UK, which has video-based exercises, and so does this new one, which I just found in preparation for this talk, which is actually made for the Irish population with ankylosing spondylitis, and they too have video exercises there. Now, it would be remiss of me if, when talking about management of a chronic disease or any disease, that we don't talk about goal setting. It's no difference with SPA or AS, and hopefully you'll agree that the 5 points, or that little flowchart that I've just put down there, is a normal way that we go about goal setting and managing people towards self-management. In our clinics, we've altered that slightly, especially for this group that presents with SPA. Unfortunately, many of these patients present with significant pain, stiffness, and fatigue, and so really, when we first see them, that's their primary concern. And we find trying to go through goals and goal setting at that point in time may not be as effective as doing it later once their disease is a lot more controlled. If I go with my pointer again, you'll see these arrows coming up on the other side, and that really acts as a reminder for us that unfortunately people who suffer from this disease have setbacks and they may have flares at times, and hence goals need to be reconsidered or reset at particular points in time. Now, other considerations to help with management, and again for all of us and all of you out there who tackle chronic disease on a daily basis, this won't be anything new. It's great to have a helicopter view of someone's health, having a look at what their goals are yet again, and whether they have any other health issues that really need to be considered. Taking a multidisciplinary approach if you are lucky to have those sorts of services available to you. And of course, we can't ignore chronic pain management, especially when we're talking about chronic diseases like AS or SPA. Hence, the reason Irwin and I guess, are speaking in front of you today is that we have a multidisciplinary clinic. And to give you an example of how we care for the patients who present with SPA or AS, this is a workflow diagram that we've created. It looks pretty complex, and it's complex for a reason, only because we feel this is the only way to get integrated care for this particular patient group. It's busy, so don't try to read through it, except that I'll point to you what the colours mean. The green that you see right down the middle is the involvement of our rheumatologists, and the yellow boxes here are really little points on the timeline that remind us about particular investigations that they need to go for. Now, when we look at the rest of the allied health team, I'll go to the next slide. In the burnt orange here, you've got our physios, and they come pretty early on in the timeline as we need to perform baseline metrology, as you see there. And metrology stands for the assessment or objective assessment that we go through specific for AS. And of course, there's ongoing monitoring. And you may see here that the metrology may occur 3 monthly and then lengthen out to 6 to 12 monthly, depending on whether the disease is active or not. If things go well, we love people to get to this pretty pink box, which is when these patients actually transition along to our exercise physiologists. And really, that means the disease process is going well, patients have been able to reset their goals, and the exercise physiologist is there to help them with keeping their motivation to exercise, of course, and to possibly do much higher level exercise for them to achieve their goals. On the far left in blue, and this is my last slide, is Flora, who so happens to be our care coordinator, our rheumatology care coordinator. And this was a service we implemented a couple of years ago. And we see it as a necessary service, especially because these patients require time. Time to be educated again, time to ask questions, because they have many of them, especially after receiving a diagnosis such as ankylosing spondylitis. And it's this education that allows them to have a better understanding of their disease, allows us to manage them better, and hopefully get much better compliance in terms of medication and exercise prescription in the long term. Also, Flora acts as a bit of a conduit in terms of navigating or coordinating the varied services that these patients may require, especially if there are other health issues to consider and other goals that need to be addressed. So that really covers very, very quickly an overview of physical therapy management of ankylosing spondylitis. I would like now to pass back the microphone to Irwin, who will go through a bit of a summary.
Gavin, am I on?
Your sound is, your camera is not.
Okay. It won't allow me to turn it on for some reason. All right, I'll just talk. So I'm sorry you don't have the camera on, but in summary, and this talk is really to try to get people to start thinking about inflammatory back pain. I hope we've made the point that patients with inflammatory back pain are probably more common than you thought of. I hope as we started to describe the features of these diseases, it might have jogged your memory about patients you may have seen. The fact is the diagnosis is terribly delayed, and there are many, many factors to this, but one of the important factors in play is the lack of recognition of the features of this disease. So when you get your handouts, please review the features of inflammatory back pain. I think that will be an important starting point. I think you need to have a decent index of suspicion. No one's going to expect that you can make the diagnosis the first time you see a patient, but if the patient keeps coming back and the story keeps expanding, they have one Achilles tendon problem, they then have a tennis elbow, they then mention to you that they've had back pain for 10 years, then the index of suspicion keeps growing. And of course, think about things which, if you can, which are a little bit even further.
Please bear with for just one moment.
Okay, we seem to have lost Irwin again. We just had a little bit of trouble with his camera tonight. We might, given we've got about just over 7 minutes before we need to finish, we'll go to a few questions that have been posed during the presentations by Irwin and Errol, which have been fantastic and so interesting, so thank you to both of you. There were an early question that came through was in relation to a woman as to whether AS could be diagnosed in a child of 12 years of age. There's a history of an uncle and a grandmother having AS. So is it possible to diagnose AS at that young age? Question to you, Irwin. Irwin, can you hear me?
Yes, I can, Janet.
Yeah, sorry, just the question about that came in through earlier about the possibility of diagnosing AS in a child of about 12 years of age.
Okay, so I can read that question. Yep. And basically it's a 12-year-old male client whose uncle and grandmother have diagnosed AS. And the boy had some sort of virus 8 weeks ago and since then has not been able to go to school. The eyes are super sensitive to light and he has pain in the stomach. All right. Firstly, there's no way that would be a diagnosis of AS, but of course this client, this 12-year-old, can in time develop AS. The reason I said he won't have AS is there's been not enough time to develop the X-ray changes of AS. But AS can be diagnosed in children. You have a condition called juvenile ankylosing spondylitis, and they can classically be quite crippled by the disease. So the age alone is not sufficient to say that they can't have it. It's just that the time period will mean that he doesn't have the X-ray changes. I've already said that the family history is very relevant. Okay. So if you have an uncle and a grandmother who have diagnosed AS and they presumably have the gene as well, this boy will have a higher chance, a 20% chance at some stage of developing ankylosing spondylitis.
Another question, Irwin, in relation to your mention about the sort of the ridging on fingernails. Does the ridging need to be apparent on all nails? A question from Bertilla.
Yeah. No. So many of... Okay, so thank you for the question. Many of us have ridges on
we might move on to the next
nails,
question.
The question is how much, how deep the ridges
are, MRI
whether they're
appear?
vertical. Okay, so MRI findings appear much earlier than X-ray findings. So if a person has good going inflammatory back pain, that's the time to do the MRI of the spine, asking for specific views to look for this. MRI, unfortunately, again, is not a 100% test. So, hello? Sorry, Jen, you've cut in and out.
We can
so
hear
what I was going to say is that MRI, again, is not a 100% test.
Okay. Given we're having a little bit of trouble with Irwin, we might just sort of move on. Actually, could I just a question to you, Errol, with regards to any specific dietary considerations for people with AS?
Yeah, but typically from an inflammatory disease viewpoint. So with the dietitians that we work with, if someone presents with an inflammatory disease, there are anti-inflammatory foods that you can have in your diet that will help. And again, a dietitian can go through that more specifically. But again, very simple things that you would suspect from having generally a good diet, such as reducing the fats and so forth, will help to reduce inflammation. The research around that
It looks like we're having a few problems just in finishing up. Look, we might finish there this evening, just given that we've got a couple of technical issues. What I'll do is actually get Errol and Irwin to answer the questions offline, and we will make sure that the answers are sent out to all participants. And of course, you'll receive a copy of the presentation and the recording. So sorry about these technical issues just at the end. I'm sure you'll agree with me that it was a most interesting presentation from both Errol and Irwin, and just fantastic to get that multidisciplinary perspective in relation to the treatment of spondyloarthritis. So on behalf of everyone tonight, I'd like to thank you for joining the webinar, and I'd particularly like to thank Errol and Irwin Lim for a most interesting presentation this evening. So thanks everyone for joining us, and good night.